Hey, good evening or good afternoon if you're on the Pacific Coast, and good evening if you're on the East Coast. My name is Suzanne Paulson. I'm the CEO and the founder of IECO, and I'm so happy that you've joined us tonight. We have a great, huge audience, a wonderful, compelling guest that you are going to love. And this is the kickoff with number 2 of our regional series, helping you, the dry eye patients, find great dry eye doctors like Dr. Ross. I'm going to introduce Dr. Ross in just a minute. I want to, as we always do, just give an acknowledgement to our panel of experts that helped us get to where we are today. That series, for all of you that have been following that, will continue in September. September 30th is the date we're targeting. And we have some really exciting things planned. But obviously, we got here today because patients were hungry for more information about dry eye. And one of the people that we just could not wait to put in front of you is Dr. Robin Roth. She is an ophthalmologist out of lovely Scottsdale, Arizona, where you've had some crazy weather. Welcome, Dr. Ross.
Welcome. Thank you for having us.
Oh, my pleasure. And we're going to get into a couple things, but I wanted to ask first, some people have been said, well, what is an elite award winner? And for the audience, these are people that we identify, IECO identifies yearly as outstanding in their approach of treating dry eye. And people have asked, well, how do you vet them? And it's their proficiency in how they are screening, diagnosing, and treating in office and at home. And it has nothing to do with, you know, how much they're doing with IECO or what they're doing. This is something we've set this platform up to be completely educational. So in that spirit and in that vein, it's about people that are exploring every opportunity there is to bring their patients relief as it relates to dry eye. Dr. Ross is certainly one of the most outstanding elite award winners we have. Dr. Ross, quick question for you. Now, it's global retina, and I know global means a lot to you, and that you guys are more than just an ordinary ophthalmology practice, that you have a big heart and that you do things all around the world. And maybe you can just share with the audience a bit about yourself, your practice, and when you really felt dry eye had to be part of what you do every day.
That's a great question. I've been an ophthalmologist for 25 years. 20 of those years were in the state of Michigan. I've always worked in underserved areas around the world and have done work in 37 countries in the world. In 2017, I took a sabbatical and worked on Ebola in West Africa and Liberia and made 27 trips. I was appalled to find out that 50% of patients that we saw in West Africa that were Ebola survivors had severe dry eye. And I ended up seeing about 6,500 patients during that time period who suffered from severe dry eye. And the only treatments we had were artificial tears. And I know every dry eye patient has used artificial tears. We opened our center in 2018, anticipating another pandemic would come to the United States. And we purposely decided to see only a few patients and space our patients, not realizing COVID was not too far behind us, but our primary focus is comprehensive retina and adding public health to that to educate our patients about their retinal conditions. In 2019, we realized 90% of our retina patients, many of whom are receiving surgeries, lasers, and intravitreal injections, suffered from dry eye. And we would refer them out and they'd come back on artificial tears and very unhappy. So we decided during COVID to do a deep dive into everything we needed, the full armamentarium of diagnostics and treatments to provide our patients with that care. It was an unusual approach, but it's been very successful. Once we realized that 42% of patients heading to cataract surgery had unstable ocular surface and that was impacting their outcomes, we really decided to do the trifecta and focus on our intravitreal injection patients and screen every new patient that came into our practice for dry eye and start to educate them early before they became severe patients. But 50% of our patients are moderate to severe. So that was our embarking, taking care of dry eye about a year ago. And hearing their success stories and not giving up on them has been really one of the big highlights of taking care of retina patients with dry eye.
Oh, well, we thank you. And I can absolutely assure you the audience is saying the same thing. Thank you so much for your commitment, because it really is life-changing. And we have some really super case studies, 3 of them tonight, that I can't wait to dive into. So with that, why don't I'm going to turn it over to you. I'll drive the slide deck and just follow your lead here. But here's patient number one. Let's take us through this one.
This is a 69-year-old professor who's so excited to finally retire, and he's moved from San Francisco. Phoenix is one of the big metropolitan areas. It's one of the big transit areas for many people getting ready to retire. He's been a diabetic, and he's been receiving intravitreal injections in San Francisco for the diagnosis of central retinal vein occlusion. So he arrives in our practice, and the first thing we do is do a reconfirmation of their diagnosis. He complained of blurred vision bilaterally, and his left eye was the eye getting injected. He's been wearing glasses, but the dry eye tech noted that he used to wear contact lenses and hasn't been able to wear them because he can't tolerate them. So that's a real clue. So every one of our new patients gets meibomography, which is screening of the Meibomian glands. Why do we screen everyone's Meibomian glands? Because it's the source of 86% of dry eye. And he was surprised to see that he had a little bit of gland loss, and he'd never heard of that. No one had ever educated him about it. And as an educator, he wanted to know more. And we did a speed questionnaire on all of our new patients, and his was really high, 22 out of 28. We actually do the speed 2 questionnaire because we're pre-surgical for many of our patients. And he agreed to tear osmolarity on the first day. We looked at the surface of his eye, and we asked him about his injection experience. And he said the day after any injection, he always had some discomfort, had to use a lot of artificial tears, couldn't use his computer. So we reevaluated him, and he actually had a branch vein occlusion, and we began injecting him, and he was interested in dry eye treatments. He began doing an echo-wise derm mask in the evening, and we also noted that his eyes didn't close all the way. So he had a gap, what's called lag ophthalmos, and we screen everyone for that because 30% of people at night, their eyes don't close all the way. So he started using seals to protect his eyes at night and some gel at bedtime, and reported that his symptoms were really improving. We actually asked him about his nutrition. He was very interested in an omega-3, and we put him on PRN. We gave him preservative-free tears because he didn't understand the difference between regular bottled tears, which look convenient, preservative-free tears. And he actually wanted to go through BluffX and LipiFlow. And that actually improved his injection comfort. He was able to decrease the frequency of his injections, which I don't think had anything to do with the surface of his eye, but he was able to go to every 3 months. We also did a navigated laser to decrease the frequency of his injections. And he really hasn't had an injection in 4 months, and his vision is improved, his comfort levels improved. So I want to show you on the upper left is some of his Meibomian glands. He's at about 50%. And he was mortified by that he'd never heard of these glands, didn't know about them. His eye trace, which is corneal topography, the pre-LipiFlow eye trace is on the bottom left, and you can see his right eye and left eye. If you just see that yellow coloration, that's the irregularity on his cornea that was preventing him from wearing his contacts and getting good glasses. Wow. And when we repeated it after LipiFlow, you'll see on the right, he was very comfortable with going back to get a new refraction and seeing better. So you see those yellow pictures. I always say topography of the cornea is like flying over our version of Camelback Mountain, which is our high point. And we didn't know if that was his true corneal topography, but after LipiFlow, it changed. And wow. I think that's a very important point for people. You know, many people with dry eyes have fluctuating vision and they're not sure what it is. Once they go through a treatment like LipiFlow, they make more oil in their tear film, which is the first refractive surface. I always say it's like if you have mud on if you have mud on your car windshield, you don't see very well out of it. But if you're able to clear that and the windshield's clear, you can get a better refraction, or you can tolerate potentially contact lenses. And so he's doing well. And that's the important point.
That's huge.
So we measure metrics, and I always tell patients it's very important to have metrics or something we can compare afterwards. And many people understand blood pressure. They might not have any symptoms, but their blood pressure is something that gets measured when they go to their cardiologist. I always tell people if you ever get bit by a bug and you have a red area, your doctor will say, well, if it gets bigger or smaller, and they'll draw an ink mark around it for you to judge or gauge, that's a metric. For us, the speed score is a really reliable metric, and it went down from the high 20s down to 4, and he
Wow.
was feeling better and was able to resume contact lens wear.
That's how you, that's quality of life. You know, that goes back to he gets his life back, because that's huge. Well,
And that's really a very, very important point. So I think a lot of our patients have ocular surface disease in the retina community because we're basically putting numbing on them every month, and we're putting betadine solution to prevent infection before we do these injections. And we're not really paying attention to that ocular surface. And many of our patients complain of pain and discomfort with injections. And if we would address the ocular surface, hopefully we can make them more comfortable with their treatments.
that's wonderful. Well, thank you so much. Here's the second one, another one that is kind of a different one, very interesting.
Yes, this is a 67-year-old retired administrator who actually came to see me for her floater. She felt that her floater was interfering in her ability to read and drive. And she had some foreign body sensation in both eyes and reported once again being intolerant of contact lenses, so was wearing glasses and using artificial tears. She mentioned to me that she loved to golf and was often on the golf course, was having trouble seeing golf balls at distance. But those put things together, and we looked at what she was wearing in terms of contact lenses and looked at her tear osmolarity, which was high. Her speed score wasn't terrible, but we did some tear testing, which was the tear osmolarity, and the inflammatory was a little bit positive. But once again, we did her meibomography, and we used the eye trace to look at her cornea and her lens and speak with her. So let's take a look at, so she had some gland loss in the meibomography, not terrible, but she was concerned about the astigmatism, and we performed LipiFlow on her,
Yeah,
and we also sent her to her cataract specialist because she had some little vessels in her eyelid margin and some little rosacea vessels. We talked to her about IPL, and she was very proactive and said, I want to do everything for my eyes. So she went through Blefex and IPL. She had about a 1.25 diopters of astigmatism. And when we did her eye trace, her DLI, which is an objective measure of her cataract. Most people, when they go to see the eye doctor and ask about the cataract, they're getting the cataract judged by the slit lamp, and it's a subjective measure. We could take 20 ophthalmologists, and they all might grade it a little bit differently. The beauty of the eye trace is that it's an objective measure, and when it showed it was decreased, we told her that she had to optimize her ocular surface before cataract surgery, and she was all in. She did the LipiFlow and the IPL, and her corneal topography changed. And she was,
that was this before and after. Wow.
Yep. So the before is the lower left, it changed, in the upper right, her astigmatism went away. So she went from 1.25 down to 0.8, and her cataract specialist said, you don't need a toric lens. So it impacted and totally changed her biometry, which fits with 42% of patients with ocular surface disease. Their biometry is going to change, and many of our patients don't understand that. And it's really a really important educational point that if they're getting ready for cataract surgery, they need to have their ocular surface checked, so we know whether those biometry measurements change, and not every cataract surgeon does multiple measurements. This cataract surgeon, because she saw our report, said, hey, we're gonna recheck it at the end of your treatment time, which she did, and said, you don't need a toric lens anymore. The patient was thrilled, and the patient's back to 2020 and happy as a lark.
So did the Blefex, LipiFlow, IPL in office, which was four times for the IPL, and then at home you had her doing the compresses, again, the omega supplements, Avenova, and some preservative-free drops. Awesome. Yep. And then and we have a happy patient. Cleared for
So,
cataract surgery.
so before we cleared her to go to cataract surgery, look at her speed score. It went down to 0. Her tear osmolarity is under 308. Her eye trace corneal topography changed by a half a diopter, which is substantial. She did not have any symptoms. We cleared her for cataract surgery. And the good point is she's back to 2020. And the reason she came to see me was whether she should undergo laser floater treatment. And I told her no, because she was going to need cataract surgery. And after cataract surgery, your floaters can shift, which hers did. And she didn't even need the floater treatment.
Wow, that's great. That's a really super example of one, how complex
really,
dry eye is too.
Yeah, but it's very, very important for us to advocate for our patients. Look at the big picture of where they headed. It's very easy for me to have said, yes, I'm going to treat your floater. Good luck. And she would have still been an unhappy patient. So we have to look front to back at everything and see what the patient's goal is. And her goal was either to get back in her contact lenses so she could see the golf ball, or get some correction to fix it. And she didn't know whether it was the floater, the contact lens, cataracts, and we were able to put it all together for her in a plan that made sense for her, and to have her cataract surgeon on board. So it really is a team effort.
That's a wonderful way to describe it. That's it. I know we're going to go on to the third one, but it reminds me also, we work with a lot of Sjogren's patients, and because it's systemic, you know, that it manifests in a lot of different ways. So often it takes years to diagnose, and then you go back to teamwork. You know, it's often the rheumatologist that is diagnosing it after they've seen the ophthalmologist and they've seen their dentist, and it's teamwork and awareness, and really going the extra mile for the patient to be able to explore all the possibilities. And thank you for that great work. That's exceptional. So we have a third one.
Yeah, probably the most challenging. She's a 67-year-old retired executive that presents to us with flashing lights and floaters in her left eye for 2 weeks. So she has been highly myopic, but had previous LASIK surgery 20 years ago. And LASIK is a red flag for us that 80% of our LASIK patients suffer from dry eyes. So no surprise that she's had 20 years. I can't even envision that, of foreign body sensation, red eyes, irritation, and she's been to numerous ophthalmologists. She said she doesn't have any fingers on either hand to tell us how many, but she's been numerous. She's been to 2 academic centers, and she just looked miserable sitting there. She'd actually brought her mother in for macular degeneration care. She's had retinal laser in both eyes. She's even undergone at a famous institution Meibomian gland probing, which she described as very painful 10 years ago with metal probes. And she's had punctal plugs that had to be removed. This sounds like a terrible experience. She's had lid surgery, multiple styes in the past, treated with doxycycline, and recently been put on hormones in the fall that are making her, as she says, a menopausal nightmare. So when we first saw her, her speed score was 25 of 28, and the second component 11 of 18. She had lash collarettes, which look like dandruff on your eyelashes, which is a red flag for Demodex. And many of my patients, when they look up Demodex and see that it's a mite, they freak out, and it makes them very scared. But we were seeing her for her floater, and she had a vitreous detachment, not to be confused with a retinal detachment, causing her flashing lights and floaters. So we explained the blepharitis, we took pictures, and if you go to the next slide, you'll see how red, I don't know if we have the pictures of her eyes, you'll see how red and inflamed her eyelid margin looks like. It looks thickened, and it was, and you can see that her nasal bridge is red because of the rosacea. You know, really 100% of our patients with rosacea have these angry lid margins with telangiectatic red vessels that grow into them. But we did her meibomography, and she said she'd never seen her meibomian glands. We always image them on a big 60-inch screen, which can look scary. But I said, this is awesome. You have meibomian glands. You actually have them. Many patients have, 90% loss. I said, there's hope. We can jumpstart these glands. And she said, really? And I think that it's very important to look at the positives because everybody has some positive that we can work on. And we talked to her about going through a more elaborate dry eye workup. She was there for an acute emergency. So we put her through an Oculus 5 and we really couldn't even get what's called a nick butt. How quickly do your tears evaporate on your cornea? Because she was so light sensitive. And she agreed to go through BlephX LipiFlow. Once we showed her her eyelashes, she wanted those eyelashes cleaned. And she invested in new lids technology to start cleaning her eyelashes at home. It was a little trepidation for her because the idea of taking something mechanical and getting it close to your eyelashes. But once we explained and showed her that new lids would do the training, they would log on with her and show her what to do and watch her do it. She was on board and her eyelashes started improving. We started seeing some slow improvement. But what I told her is with all dry eye patients, this is a chronic condition. We might take 2 steps forward and a half step back, but we're going to stick with it. She had some setbacks with a few styes, and we finally curbsided a dermatologist who recommended oral Oracea because she wasn't tolerating the doxycycline because of stomach upset. And this helped her rosacea quite a bit. We couldn't treat her with IPL while she was on the rosacea, but we've now gotten her to a really stable state. We've had to do the tea tree for the Demodex. She's been doing the daily eyelid cleaner. During her setbacks, we used Isuvis, which is a low dose steroid that was FDA approved in December of 2020. We also worked on stress management. She had a family member, her mom, move in with her that required full-time care. And that's not easy, having family members living with us. So let's go to the next slide. So the right, so the changes that we experienced on the right is her post. Those green areas are her cornea actually improving. So the tears weren't evaporating as quickly because we started seeing oil on her cornea. So if we can go back to your last slide, Suzanne. Her lashes were free of debris. 7 months have gone by. Speed score has dropped dramatically. She's comfortable. She's getting back to entertaining. You know, she stopped entertaining because of the appearance of her eyelids and face. It was somewhat of a surprise to her. And I think we're all a bit self-conscious. We want to look our best when we have guests over. And having red eyes isn't something we want to, doesn't make us want to socialize.
And it's associated with other, it's like being tired and fatigued, and it's one of the #1 symptoms of dry eye. And I can't believe that we only have 7 minutes left. Okay, hold on. Okay. I'm gonna go. We have all kinds of questions for you. Okay. I have to put my readers on, forgive me, but here we got it. Let's see. Are there any new promising studies, eye drops for extreme dry eyes? Are you or any of your patients involved in any dry eye studies? We're getting ready to start a Demodex study. So I think the Demodex Blepharitis studies, we do clinical trials primarily with Retina, but we're just getting ready to start for us intersegment studies. And Demodex has been a major cause of blepharitis and itching. So that's the one study we're getting ready to start. Regenerize has been an eye drop that many of our Sjogren's patients and post-buccal retinal detachment patients and some of our severe dry eye patients have found indispensable. So we've really been a bit advocate. I think that drop puts good, the way I describe it to my patients is we have inflammatory components that really tackle our cornea and don't do good things for our cornea. Regenerize tends to put good factors to combat that. And many of our patients find it incredibly comforting and really helps them minimize their symptoms. New, right? It's been around for about a year. Okay. Yeah, with COVID, a lot of things I think were kind of missed because they normally would be out to market probably faster if we didn't have that shutdown. So that's encouraging. Another one, what is your opinion on using Procara for dry eye? How many days do you recommend using? I really like to see if our Procara patients can keep it on for 5 days.
I found that having a little bit of tape, we have this special tape that comes on and off on the upper lid, really helps them tolerate it. But I do think Procura is a great thing for our severe dry eye patients. I use it in acute corneal abrasions, patients that wake up with corneal erosions, some of our post-LASIK pain patients. Um, so
Okay,
I
great.
I think it's a great product.
You have so many questions. It's really great. And if we can't get to all of them, we'll answer them via email to everybody. But here, what is the deciding factor for how many IPL treatments a patient receives? Like one of your case studies had 4 and one had 8.
Yeah, I think, the severe patients, especially the severe ones with rosacea, tend to be the ones that will do 2 4 sessions. But most patients do really well with the 4 sessions. I think the rule of thumb is 15% improvement after 1 IPL, or up to 50% with 2, 85% with 3, and 100% improvement with 4.
Wow,
I've never yet had a patient who said to me, I wish I didn't do IPL.
that's great.
They're more scared of what does it do or not understanding. I think it's helpful for them to see a patient go through it. All my staff, believe it or not, suffer from dry eyes and they've gone through it. We look at it as a perk to work here that everybody gets their dry eyes treated and managed. But I think it's more prevalent in the United States than we give it credit because of computer use. But I think patients love it. I think they do amazing. But I think the important point is after we do a treatment, we bring them to a slit lamp and we make sure we gently express them to see that oil coming out.
Got it. Yeah, that's super. Now again, you're out of Scottsdale, Arizona, and there are people that have registered for this that are all over the country, even some from Australia and from the UK. So if you're outside of the area, do you have any recommendations of how patients can find great dry eye doctors, questions or things to ask?
Yeah, I think that, like, for example, Luminous that makes our IPL machine, I think they have a posting of who has IPL machines for dry eye in the United States. I think it's really important if you're going to go to a dry eye center that your Meibomian glands can be imaged, and that's called Meibomography. And I think a lot of optometric and our ophthalmology colleagues have the ability to do that imaging. We do it free of charge on every single new patient that comes through because we think it's a public health crisis. And we think everybody should be imaged at some point in their lives or career. We're seeing meibomian gland loss in young people, in kids. None of the treatments like IPL and Lipoflow are approved for kids, but at least we can start to be cognizant that we're giving all these kids computers and iPads from 2 years on up. We could be impacting them becoming partial blinkers where these meibomian glands begin to disappear. So even if we're a dry eye sufferer, we need to think of our kids and grandkids as well.
That's an excellent point, especially with COVID, with the homeschooling and the learning from and all the Zoom calls. And we've brought that topic up a lot, and that we've seen case studies where a 20-year-old will present with glands that they're 70-year-old glands.
Yes.
Have incredible dropout. And it is alarming because for most of the audience out there, and if you don't, once they're not like teeth where you can get an implant, there are no implants for your meibomian glands. When they're gone, they're gone. So you want to preserve. I mean, so much of managing dry eye is preservation, like get it to work as best you can and then keep it in that state. So it's that's wonderful and good for you for doing that as a complimentary service. So if somebody was coming into your practice, what would that look like for a dry eye workup? What's your process? How do you take?
Well, we have 2 pathways. So the first pathway is usually they're coming in for a retinal evaluation. So we're primarily retina. So we're doing a comprehensive eye exam no matter who they are first. And they'll always get screened with meibomography. If they want a more extensive dry eye workup, that means that our dry eye technician is putting them through tear osmolarity, inflammadry, a whole oculus, looking at 7 points in their tear film from their lipid to their oil. And we're looking at how quickly their tears evaporate. And we're coming up with a comprehensive paper plan. We're going to hand them a handout like these things are what you need to do. These are things you should consider. And these were your readings today. So they'll decide what they want to do. every single patient will get a video program for them based on our Rendia video library. We'll put together and we'll send it to their email before they even leave our office. So
Oh,
they can go home and review all the educational materials we talked with them about. And
good
then
for
they can
you.
email us back in with any questions that they're helping to make their decision on what they want to do for treatment. You know, I tell them there's good, better, best. Not everybody can afford IPL and LipiFlow. So, but I do make the analogy, just like when you're a kid, you learn to brush your teeth, toothpaste and toothbrush. You didn't have dental care, you'd still do those things. If you can't afford those things, you should at least do eyelid cleaning and a derm mask as a basic. And that's basic hygiene we should be doing to protect these glands.
Yeah, good for you. That you are so far ahead. Now this is why you're an elite award winner. I just think you're just the best. I can't thank you enough. I can't believe we've already gone 31 minutes in. So
Well,
I know you're a very busy doctor, and I just appreciate your time, taking some time to visit with the audience and share some exceptional knowledge. Again, it's Dr. Robin Roth in Global Retina Institute in Scottsdale, Arizona. Clearly over the top in their expertise in their patient care. And if you're looking for a great dry eye doctor in the Arizona area, reach out to Dr. Ross. Her contact information is right there with the phone number, and you can always contact us if you need to as well, and we'll point you in that direction. We will have another great doctor on next week. We have Dr. Cassis coming in next Thursday and another one on the 29th. We're going to continue this series, but again, Dr. Ross, I just can't thank you enough for your time and everything you're doing for dry eye patients.
thank
Really
you so
appreciate it.
much for having us.
Our pleasure. You enjoy your evening, and thank you, everybody. Hope to see you next week. Enjoy your evening.